All right, ready to go. God, she's blowing her off again? What is happening? Okay, so, all right, well, you wanted to see the exam. I'll bring it. You're going to be here Monday? I'll have everybody else can look at it in the lab. We can look at it real quick. Okay? Well, good. So let me start here. This is where we kind of ended it. Again, remember we talked about the facial nerve and Bell's palsy. Remember Bell's palsy. I think that's really important. Again, the exit point, and these are the important ones: stylomastoid foramen, motor to the face, sensory to the tongue. Remember the division of the tongue: anterior 2/3 is facial. You'll see the posterior 1/3 is glossopharyngeal. And again, there's a lot of ways you can test for this. Testing taste, just having people do facial movements with their eyes, blinking, winking, smiling. Oh, I thought you blew us off again. You managed on the other day, but I digress. And don't. It's all right. We're just reviewing Bell's palsy, which you didn't hear anyway. And that's important. That's potentially a test question. Probably is. Down the road in the future. And I really, because you're going to know people with Bells. You really are. You weren't raising your hand. You were just.
Yeah, I was.
What's that?
We have like one more test and then the final's cumulative.
We have two. Final is not cumulative. We have the test I sent you the study guide for, right? And then we have another test after that. That test will probably be. This is week 8. Let's say 10. Probably maybe. Obviously, you're going to get hammered before Thanksgiving. You always do. So you got to test probably immediately pre-Thanksgiving.
Okay.
Along with everybody else. Somebody we know over there who teaches your other 2 classes.
Yeah.
So what?
2 more tests, including the final?
No, there's 3 more. The one we have on the 29th, another one after that, and then the final.
There's an exam on the 29th?
Yes. Do I come to class more often?
I always
don't necessarily come to class.
I got me sick.
You gotta stop. You gotta stop. Those Thursdays are getting to you.
We have a physics exam on the 29th.
Yeah, what?
Can't you make it the 31st?
Oh, happy Halloween. I'm good with that.
Okay. As long as it's not on the same day as physics. So.
Why is physics not that hard?
Oh, physics is terrible. It's so bad.
Why? Well, is this physics 1 or 2?
2.
Oh, do you have triple integrals and stuff like that?
I don't even know. It's traumatizing.
It's math.
That's not math. That is like
Key to the universe. Is it quantum mechanics?
circuits.
Oh, circuits, yeah. Yeah, I'm bored with circuits. That's a pun, or 2/3 of a pun, PU. I give up. So back to, this is Bell's palsy. Read about that. That's common. If you're going to know somebody with it, you might end up with it. Most of the time it goes away by itself. Yeah, I don't have anatomically, graduate anatomy, you would have to know all these branches. It's different necessarily. They're not the same as the trigeminal nerve, which you should know the 3 branches of: V1, V2, and V3. So temporal, zygomatic, buccal, we don't have to know all of that stuff. So it has a rather large number of structures it contacts. And remember, it doesn't have anything to do with the muscles of mastication, even though they're pictured on some of these diagrams. The only 2 cranial nerves, the only cranial nerve rather, that does not leave the skull. It used to be called the auditory nerve because they thought it was only hearing. It is effectively, you're going to see a lot of named nerves, sciatic, are really 2 nerves wrapped in one. So the vestibulocochlear nerve is just that. Vestibular is balance, and we're going to look at that Monday in lecture in lab. We're going to start looking at the anatomy of the eye and the ear, the eye particularly first. So the cochlear division is hearing, and it goes into the cochlea, which is the end organ for hearing. And this is the vestibular division goes into what are called the semicircular canals. And they're the best analogy for them you'll find out is they're like a carpenter's level. And so they enter, pass in the inner ear through the internal acoustic meatus, and that's it. And they're sensory with a tiny amount of motor. The motor is merely adaptation. Again, adaptations to loud sounds. You know, maybe you hear this when you come into the room and you sort of tune it out. You can have auditory adaptation, and the same thing with balance. If you're on a roller coaster or something like that, it may affect you, it may not. Any of those, think of that myriad of Kennywood goodies that my kids used to put me through. They just like to see their dad get nauseous. And you saw them, how sweet they were. Okay, and so the small motor component for adjustment to sensitive, it's well phrased there. And here's the auditory nerve. We will go over the anatomy of these structures, which you can see it terminates within. This is the internal portion of the temporal bone. You saw how small a temporal bone is. I mean, we're talking about the size of a split pea for the cochlea when you get to it. And we're going to go, when we look at the ear, we're going to look at these other three bones, the hammer, anvil, and stirrup, incus, malleus, and stapes. We're going to look at the eardrum and a little basic primer on how things go wrong. So obviously being unable to hear. It's interesting that when this is effective, they oftentimes, the eyes start to go in funny directions. So there really becomes, they used to do this. And again, this is not something, it's more information on anything else. They probably still test this, but they use a thing called calorics. Calorics, where in the old days, they have somebody lie on their side and they either put hot water or cold water into their ear. Obviously, not going to go through the eardrum, but that temperature change would cause rapid eye movements in different directions. And then they stopped doing that. They used hot air and cold air, and they went back to cold water and hot water. But it's all that aside, it's very temperature sensitive. And that's when they talk rapid involuntary eye movements, balance. And that's what you know. Some people just have, best way to describe it's thing called vertigo, where you're just very, very difficult. I manifest it as car sickness. So, I mean, I prefer to drive than ride. Now, again, if I ride in the car, I would much rather have, I can't read in the car. So, I mean, if I'm checking out, I'm getting better with watching a game on my phone. That's about the side of it. But I would rather drive, but my wife doesn't like the way I drive, so she drives. It's how we get along so well. So those nerves, 7 and 8, you'll see they emanate from roughly here. We call this the medullary pontine juncture. So 7 and 8 both come from here if you're interested. And here the gloss, and all these last 4, these are all from the medulla. So as you get lower and lower, now we're getting to these, this is a big problem. Damage here in the medullary area indicates significant problems. You're in the brainstem deeply. And now with a problem here, it usually has very significant repercussions. If we start to see fault in these, something's going on inside the brainstem, and generally the prognosis gets progressively worse. 9, 10, and 11 all exit the skull by way of the jugular foramen. You're going to see 11 actually has a component from the spine. It's a spinal nerve component. So this first one, glossopharyngeal, literally tongue and throat, innervates the posterior 1/3 of the tongue. Okay, it innervates basically that deeper part of the tongue, and pharynx for swallowing. So the back portion, or the throaty portion of the tongue. And again, glandular fibers. This is important. It goes to the salivary gland. You have 3 salivary glands. We'll cover in digestive. The sublingual and submandibular, the ones that are tongue and jaw associated, those are innervated by the facial nerve. I should have pointed that out, but if I didn't, you should be aware of that. The largest of your salivary glands is here is the parotid. Generally, when we have affected, you get dry mouth because that really produces the bulk of the saliva. It's from the parotid gland. We'll see that when we get more into the physiology, the digestive, and particularly the physiological aspects of digestion. So there you are. Sensory, taste, feel a sensation in the throat, taste from the posterior third of the tongue. Okay, and this is really important. In the carotid, where the carotid arteries bifurcate here, in the aorta, where it exits the heart, which we'll look at both of these structures going forward. These are important chemical and pressure sensors that control heartbeat and respiration. Really important. So, and that's what I mean. Now you're starting to see these are major factors. The baroreceptors, okay, these are the ones that are so important. When you get up, you jump out of bed in the morning. With older people, you can lose your balance and be right down. Next thing you know, you have a bad fall. It's called orthostatic hypotension. That's because those sensors are not quite as sharp. And they're not making sure the blood supply to the brain is maintained at a constant level. They control heartbeat as well. We'll get to all of that when we look at the cardiovascular aspects of it and the respiratory aspects of it. But this is why we're getting into that brainstem area. Oh my goodness. So voila here, injured or inflamed glossopharyngeal nerves. So having somebody swallow or being able to take taste in the posterior part. Big reflexes here, gag and swallowing. Gag reflex is really important for you. As people get very much older, the gag reflex is less acute. So they have a lot less trauma. They don't gag quite as much. I don't know if it's necessarily good or bad. I probably think it's bad. But in general, that's the type of thing. When you say stick out your tongue and you get a tongue depressor, and you start to get back, and let's say you take a sterile cotton tip applicator. Did you do swabs like that, throat swabs in micro, in the lab? For Dr. Dress? It isn't that long ago. We have a maybe. A definitive maybe. I'll give you a definitive maybe. Okay, I owe my students to it. To check, you like do a swabbing for strep throat. How do you know you're back in the right area to get the swab? People gag. So you're in that way you're checking the gag reflex. That's how you're checking. So all that's important. There's that big parotid, the ones over here. If you ever saw somebody with the mumps, this is what gets inflamed. You don't see a lot of mumps because of MMR, measles, mumps, and rubella immunizations. Here's they all have their little identity. The vagus, the only nerve that exits the head and neck area. It gets its name because it's a vagabond. It wanders. Okay, extends beyond the head and the neck. Exits by again the jugular foramen. It's still from the medulla. It has parasympathetic fibers. This is all about the abdominal, the thoracic and abdominal viscera. It's about your heart rate. It controls your heart rate. It's about your digestive features. Okay, it's about breathing. For instance, I had part of my vagus nerve removed going to my stomach as part of my ulcer surgeries. So we'll talk more about that when we go back to that. So that's its parasympathetic function. Going to structures we do not have conscious control. You can't control how, without medication, obviously, or other things, be able to control how much acidity your stomach makes, or be able to control your heart rate. I mean, maybe you can meditate and get it to calm down, but you really can't, quote unquote, consistently control it. So all of those, again, baroreceptors, chemoreceptors, still some sensory taste buds. So it's both motor and sensory that are there. You can see the extent of it. And so interestingly enough, it's the one that it basically creates a certain amount of motor activity to your larynx. So imagine if somebody has head trauma and they're hoarse. That's something that points, you know, before you heard them speak normally, and then all of a sudden they're very hoarse. That's a little ding, 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 ding. We better make sure the vagus is unaffected. So laryngeal nerves, voice box, vagal nerve paralysis, hoarseness, loss of voice, etc., etc. So I mean, that's one good way to, or you have to have an index of suspicion. You can see the quite remarkable extent that's there. This is the only one that has a spinal component. Tiny rootlets, those little segments from the cervical region, the upper cervical region, the spinal cord, not the brain, in addition to where it's coming from the brain, go up through the foramen magnum, join this accessory nerve as it exits by that same jugular foramen. And its big muscles, these two super important muscles, the trapezius, have somebody shrug their shoulders, sternocleidomastoid. Have them do this. Sternocleidomastoid allows you to do this and move your head from side to side. Just put something on your shoulders. Okay, move your shoulders against me. Shrug them. You should be able to do it just fine. Same thing with this. Again, muscles are strong. You're not going to be able to overpower them generally, unless you get somebody who wasn't playing defense for the Steelers last night. What a bunch of wussies. With a W. If you tell me they'd scored 31 points and Rodgers was over 4 touchdowns, I'm like, yeah. Still an excellent game. A very interesting game. Yeah. Yeah, there's no such thing as a good loss. It's a loss. I digress. So they used to call it the spinal accessory nerve. Again, shrugging your shoulders, blah, 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 blah. Here you can see little rootlets come up and then out. Easiest one. Why did I have you identify the hypoglossal canal? Stick out your tongue. Easiest thing in the world. So it's basically, it's motor, obviously, but obviously, since you know your tongue's sticking out. When someone sticks out their tongue, again, normally if you stick out your tongue, it'll go straight. It's going to one side or the other. Same thing with the shrugging of your shoulders. The affected side. You're not looking for the opposite side. It's the same side deal. So if the tongue's going, there's something going on over there. So how do you go, oh, stick out your tongue straight. I am. We'll do it again. And if it's listing, problem. We see this a lot. Someone's if you're going into a clinical field, you'll learn about if someone's in a coma or someone had a really bad thing and they were having real trouble, something bad happened to them. They threw a stroke or a big blood clot and they're comatose in bed. All of a sudden you see they start to do this. Or elderly people are getting close. That's called positive OSA. You'll hear this. And then what's worse is when they get Q. That's Q side. Their tongue's hanging out. So it's not trying to be flip about it, but that's how you hear doctors converse to each other. Oh, yeah, they got their OSA positive. So I remember when I was a student doing a rotation down in Virginia, one of the residents said he's presenting the case to the attending. And so and so was admitted last night, blah blah blah. This morning we came in, examined him early this morning, 6, found he was this. We had abnormal reflexes, and he's OSA positive. The very first thing out of the attending's mouth is you put him on the critical list, because that's a protocol that has to be followed. If somebody's in trouble, you better start critical list. Maybe we have to move him to intensive care. And God, he didn't last a day. Yeah. It's unfortunate. I don't mean not painting it lightly. It was again. It's my memory's very acute. So it points toward the affected side. You're done with the cranial nerves. So all these bad boys down here. So ocular. This was oculomotor. This was trochlea. This was trigeminal. This is abducens. The last of those lateral rectus 6. This is facial. This is now the vestibular cochlear, and then you're starting to get lower and lower into that area. There's that chart again, and I'm not going to go through all of it. Spinal nerves. Spinal nerves, the numbering is a little different. Most of the time, typically. So if this is L1, this is L2, what happens is the nerve comes out between the one below it. So this would be L1, this would be L2, etc., etc. And that is true for effectively all of these except cervical. So we have 8 cervical nerves. Because in cervical, if this is, say, foramen magnum here, and this is the atlas, C1, okay, and this is C2, C1 comes here, C2 comes here, C3 comes here. So effectively, they go out to the one above, okay, and that's the difference. Normally, it's the one below, but the oddball is cervical. So we have 8 cervical nerves, 12 thoracic. And yeah, in fact, we have an extra one, the cervical area, one normally coming out below. 5 lumbar, 5 sacral, 1 comes. And they're tiny, that's the joint. And effectively, they're all mixed nerve, dorsally, sensory component, vertically, the motor component. And they all go different. And the funny thing is, particularly in the cervical area, the lumbar and the sacral area, they go through a very interesting bit of sort of magic, and they do what's for, and you see it, they form a plexus. You're going to see as we get, it's almost like they begin to overlap one another. As they exit, they begin to almost intertwine and set out separate branches. You'll have to see, I can't describe it. This. And so this is, and the names and the nerves that you and I know, like the sciatic nerve, the femoral nerve, the musculocutaneous, the radial, the ulnar, all of those nerves are basically what's coming out of the plexus eventually. There's a whole way of remembering it. There's like root, branches, cords, and medical school anatomy, you have to remember. That's one of those things, unless you're going into neurology, you kind of, what I call LTF, learn to forget. And you guys do that. Stuff that you got to learn, and then you're not going to use it again. None of which would be in this class, or Dr. Hillary's class, or Dr. Buxton's. That's all important. You have to remember every single bit. Why is nobody smiling and laughing? Does Sadie always take Fridays off?
No, she texted me. She's dog sitting this.
She knows how I appreciate that.
But she was about to she used to drive from Fox Chapel-ish to here for her classes.
I know where she lives.
Yes.
Generically.
She passed out before she was leaving.
Oh no.
Yeah, and I was Sadie, what happened? And I mean, she didn't go to her morning classes because she said she was really stressed out.
Oh no.
So,
You all right?
I don't know. She's texting me.
Yeah,
so
she probably. I mentioned my kids all went to the same high school.
Yeah. So she's taking the week ventral. So hopefully she.
I hope she feels better. So here's the idea. Each of the first 7 exits the vertebrae canal superior. The last one exits the canal inferior. The way I explained it, I think, is a little easier to remember. It doesn't matter. It's not a big question I would ask you. So everything else is inferior is generally the way to go. You see this? I don't get a lot of this illustration, but these are the plexes. You're going to see the cervical plexus. You're going to see the brachial plexus, the lumbar, and then the sacral plexus. That's the talking points we're going to have. Thoracic is interesting. They don't have it. I think thoracic is all about particularly going to the chest and the intercostal muscles, the muscles in between the ribs. So they don't divert. They have pretty much a singular role. Where these plexes, particularly the brachial, the lumbar, and the sacral, are all about the extremities. And cervical has a very, very special role as well. So each nerve is connected to the spinal cord by its ventral root, which is motor, efferent, outgoing, sensory, afferent, incoming. Their brain and then all those little rootlets, and they generally form a nerve. You saw this before. And I don't go into all this jazz with the rami. I mean, this is stuff like, for instance, these dorsal rami. Now the nerve is blended, so this even has motor and sensory. Let's say involve the back musculature, that kind of stuff. This is part of what's called the sympathetic chain. We'll get to that. We don't even do that in this anatomy class. I talk about it a little bit. But to me, sympathetic is more of a physiological chain than an anatomical chain, so don't worry about it. Okay, spinal nerves emerge by the respective intervertebral foramina, and the roots become progressively longer. Okay, because as the cord truncates, ends L1, L2, now you have these long nerves coming out. And again, the horse's tail, called equine. Spinal nerves are short generally, okay, and then they have all these rami and something go to the meninges and they communicate with each other. Rami communicantes. Don't care. Again, becoming a neurologist, then you care. So I mean, here. So a lot of this stuff. So for instance, this is thoracic, this area, and you can see it's all about really what's going on with the internal and external intercostals. If I'm feeling frisky with nothing to do, and it probably will be, I'm sure my wife has someplace she has to go, and I'll undoubtedly supply you with another. I probably owe you another lecture on muscles. I'll try to get that done as well, at least one. I'm getting there because that's the next one: thoracic and abdominal musculature, particularly. Roots, line, meaning, and roots, purely sensory. Don't care. Plexus. So all ventral rami, because we're talking about these plexes, except T2 through T12 form this interlacing is a better word. Only the ventral rami form plexes. And again, once it's a rami, even though it's ventral, it is already mixed. It's the part after it mixes together, it's the section that comes out. So it's both motor and sensory combined, as you will see. Okay, and all this crisscrossing that occurs, it's easier to show it. It means each limb muscle is innervated by more than one spinal nerve. So if one nerve, if let's say this involved part of this, so a lot of these will be T4, 5, and 6, T7, 6, 7, 8. So if there is damage to T6 isolated, you can still use it. So there's a lot that overlapping is like a backup system. And that's the type of thing that we're able to, with sophisticated testing of sensory and muscle, you're able to discern. There's a whole field in and of itself which is very valuable. It's called electrophysiology. It's kind of what we're going to use the technology for when we get into the technology lab. I had it set up for Monday, but I just was much better today. It would have been much better if the Steelers won, but I don't. So C1 through C4, cervical plexus, mostly cutaneous stuff. This is the one to know. Effectively, it has pieces from C3, 4, and 5. Phrenic tells you what it does. PHR for phrenic, PHR for diaphragm. I don't know of another structure that has a PHR anatomically in it. You can't possibly forget it. Why is that relevant? Okay, when somebody breaks their neck, someone has a fall, and typically this would be an equestric fall from a horse. One of the things you worry about is a C3, C4 fracture. That's, in the old days, that was called a hangman's fracture, because when they hanged people, that was the part that was fractured. So the broken neck and eventually their breathing. That's the big issue. So when someone is a quadriplegic, the biggest problem they have immediately and potentially long term is inability to breathe or breathe properly, even if they regain some of it. So that is usually the proximal cause of their death, typically is respiratory depression or pneumonia. Example, Davis. Wonderful actor, hardly ever wanted to be an action hero. In 1979, they did a wonderful presentation of Superman. It's the first real Superman movie, big screen, modern effects from the old days. His name is Christopher Reeve. So he did 4 Supermans. Strikingly handsome, classically trained actor. Very soft spoken. You had to really lose a lot of weight to keep his. He's a big guy, like 6'4". Probably knew should have been 6'4", 250, not 2.25 he was for that. In that nice spandex suit. After he finished his 4 Superman roles, he was very fond of equestrian. He fell, of course, when he was doing equestrians. Broke his neck. And famously, quadriplegic, he gained a limited amount of function, which is not uncommon. Back, limited use of his hands. They had to intubate him initially because he couldn't breathe. They were able to, and eventually he actually had a permanent trach when he was able to breathe. So they had a tracheostomy, an actual opening. Eventually, he succumbed to pneumonia. That was eventually. I feel very sorry about it. If you just Google Christopher Reeve, it's a very interesting actor. Actors who have played Superman have had some difficulties. He had one that was accidental. The original Superman TV show from the 50s, he died of suicide. George Reeves with an S at the end of it. No original Superman, black and white TV fans. Noel Neal. He had 2 Lois Lanes. I used to get up in the morning and turn the TV on even if there was nothing on. In addition to my other addictions, I'm a TV addict. So that's the phrenic nerve. Don't forget it. This is it coming down here. So it's got branches, and this is what I mean by a plexus. You get a little piece of C3 and a little piece of C4, and eventually they join together. And it shows you what they have. I'm interested in the phrenic. So he cups from the phrenic nerve because it's really a diaphragm aspect, respiratory arrest, mechanical respirators, etc. Brachial plexus, upper extremity. Rami C5 through C8 and a little bit of T1, even some C4 and T2. There's variations. And this is what I mean. Roots, trunks, divisions, cords, and branches. So we used to remember the acronym, made up something for it, like RTDCB. They would ask you. And so what roots were involved, what trunks were involved, and now the anterior and posterior, that's significant because it kind of tells you what's going to innervate. These are all going to the upper extremity. And then whether they're, and so it's a really good illustration. This is what's going on. So as you can see, the anterior is sort of this yellowish color, the posterior is sort of this greenish color. And really there's 5 nerves you need to know. Okay? And so those 5 nerves you're going to see are in the anterior division. There's musculocutaneous, there's median, and there's ulnar. In the posterior, in the green, there's radial and axillary. Those are the 5. But you know, there are their names. So these, okay, and it's really straightforward what they have. The only big muscle to really worry about from the axillary is the deltoid. All the other, effectively, all the other posterior musculature is the radial nerve. It's easy. One nerve fits them all. So it's almost what it doesn't innervate. And the ones I will ask you. Again, at a graduate or medical school level, a lot more complex. Okay. Anteriorly, musculocutaneous, the big muscles here. Biceps brachii, brachialis. Okay. Much more limited. The median nerve, hand surgeons call it mother median. Basically everything. The ulnar, very limited. Basically it affects, and we used to learn it this way, the pinky and about half the ring finger. But the big ulnar nerve, notice right over there, along that medial epicondyle, or in this case, on the medial epicondyle, that notch is there, that's your funny bone. Not so much to call it humerus, it's because the ulnar nerve is right against it. When you whack it, as we all have, you get, you know you did. So, innervates the deltoid, teres minor, skin and joint. Deltoid is a big player. Try somebody who lifts like that. Musculocutaneous, biceps brachii and brachialis. Median, most flexors, most forearm pronators, most wrist and finger flexors doing this. big player. I remember a case where a kid decided to do himself in. They always cut themselves the wrong way. For us, we should do it like that. Just saying. And so, I mean, it was, and I'm working with a hand surgeon. I'm on an OR rotation. I'm working with him. And she's showing me what to do. And he said, this, and the first thing he said, median nerves intact, other median. And then he went by putting it all back together. Really interesting. And I'm like, thank God I was able to answer a couple of questions. I was in good shape. And so, and the ulnar, flexor carpi ulnaris, which I'll tell you about. So it's like this. The intrinsic hand muscles really don't move a whole lot. Medial aspect of the hand. In general, again, if you're going to, and the same is true when we get to the foot, it's like 3.5 to 1.5. Thumb, index, middle finger, half the ring finger. Median nerve, the other is ulnar. Let me show it to you. This is in the axillary area, brachial plexus. When we do regional blocks, I've seen them, you can operate on an elbow by doing a comprehensive local anesthetic block into the axilla. You've got to know what you're doing. I mean, there's a whole lot of stuff that you can get in trouble with. So the anesthesiologist will do a block like that. It just goes through all the different things. You want to read it? So brachial plexus, this is a big one. Okay, weaken or paralyzed. So football player, your arm extended, blows to the top of the shoulder. The other thing is crutches. If you ever have to use crutches, they're not designed, you don't rest them in your axilla. You can get a transient or even permanent kind of what we used to call a nerve palsy or causalgia. So basically, it's supposed to be against your cage. Now, we did that a lot. I had patients on crutches a lot. If I in the hospital, would send them to physical therapy. They could fix the crutches, send them down there to go into crutch walk. If it was in the office, you have to make it in such a way that you know the height, and you want that padded area on the crutches in the old wooden crutch days to hear. That's why you rest them against your chest. There's a right way and a wrong way to use crutches. Yeah, and this is median nerve, difficult to pinch or grasp. Carpal tunnel involves the median nerve. Okay, and this is what this is what I was looking for with wrist slashers. So, I mean, when you're carpal tunnel, the tunnel, there's 3 tendons in the middle, and I can tap it now and feel it. Because most of us have a certain amount as you get older. It used to be a lot worse. So people used to drive with their hands on the steering wheel like this. My mom typed for a gazillion years, and they didn't have the ergonomically designed, whatever ergonomically means. You always see that it's ergonomically designed. What the hell does that mean? It's like, you ever go? If they send you to therapy, like marriage counseling or kids counseling, one of the therapists looks at me and goes, "Does he perseverate?" I said, "I don't know. I perspire a little." It's like they want to use big words. That means persevere, persist. They nag it at death. That's if you ever wonder, that's perseverating. I have a better vocabulary than you do. Don't start with me. Perseverate this. So other thing, ulnar nerve, claw hand. Oh, this is very apropos. If you have Amazon Prime, go on. You can see all those wonderful old horror movies are on there, and you can watch them for free. My personal favorite, Bride of Frankenstein. Brilliant, 1935. Sequels are normally not as good as the original. This is better. A wonderful James Whale. There's a wonderful biography. Okay. And a famous line, there's a great movie with Sir Ian McKellen, because he was openly gay, James Whale, when nobody was in Hollywood, 40s. And Sir Ian was gay, betrayed him. And it's just, the movie is freaking brilliant, absolutely brilliant. Absolutely, absolutely great. A very slender, trim Brendan Fraser was in that movie. The late, it's coming, it's coming. Famous Family. Uh, no, come to me. Acting Family. Oh, I hate when that happens. She was British, but it'll come. Nevertheless, that's if you get a chance, see that movie. It's called Of Gods and Monsters. A very famous line from that. That movie was an hour and 10 minutes, and it's hysterical. It's clever. It's brilliant. It's in black and white. Go see it. It's Redgrave. So Susan Redgrave, Susan, I think, and she died. I think. Very interesting. Very interesting. So wrist drop. This is the Saturday Night Paralysis. This is the same thing with crutches. You have your arm draped over, and your arm falls asleep. This is why. Not that I know, not that any of you maybe saved one, have this happen to them. Just doesn't get it. Or Sadie. We know there's a problem. I'm joking.
She's always got something going on.
Doesn't she though? Lastly, lumbar and sacral. Basically, the way we used to consider more ones. The thigh and lower extremity is really straightforward. Okay, it's divided into sections. You have an anterior, median, posterior. The lumbar, okay, the big nerve coming out of the femoral. Femoral nerve is basically quadriceps, knee jerk, obturator, goes through that obturator foramen, groin muscles. Those are the two big players in that. Sacral, all about one nerve. And it's really two nerves wrapped in one. Just like the vestibulocochlear, we have a great name for it. It's called the sciatic nerve. And it consists of the tibial nerve and the common fibular nerve, and they divide behind your knee in the popliteal bone. So they're really, those are the ones to think of. So here are the two. So medial and the anterior femoral quadriceps, that's the knee jerk. Obturator, have somebody work on those adductor muscles, push against them. You can test that really easily. And there's, I mean, I'm trying to give you the major ones because that's all I'm interested in. Here you can see the obturator going through the obturator foramen. Femoral has branches that go all the way down. This is called the saphenous or saphenous nerve. There's a lot of sensation all the way along the interior of your sort of like your inner thigh, inner leg, all the way to the top of your inner or medial foot. It's there. So there's a lot to it. A lot of them they'll wrap around laterally, lateral femoral cutaneous. And then so you can look at those there. And then lastly, the big player. Thickest, largest by definition, thickest nerve in the body, longest, innervates the hammies. The one adductor is the giant adductor magnus, muscles in the leg and foot. Remember, it's the two components, tibial and common fibular. If it's common, it's going to branch off into either anterior posterior or medial or lateral, and you're going to see this when it comes to the fibula. Tibial, again, there's a sural nerve that's there. That sural implies the calf, but the big deal is it really is innervating most of the leg, and then when it gets right behind the medial malleolus, where you can feel that posterior tibial pulse, that's an important area. Ouch, that hurt. Medial and lateral plantar nerves. And in this case, medial plantar nerve is the big one. That's the one that's like big toe, second toe, middle toe, and most of the fourth toe. And then the lateral is more of the outside. The medial is a little bit bigger coverage. Okay. And then you can see other parts of it are also there. Gluteal nerves, pudendal nerves, but the big player is up there. The common fibular, oops, almost missed it. It used to be called peroneal. It's a little confusing. They dropped the term and turned it. Peroneal means calf, but it's like perineal, which has to do with the area in the anogenital area. Innervates the knee, skin, leg, muscles of the leg. And so you can follow all of those things, and this is where it begins to change. You get the common goes to a deep fibula, which actually changes, and a superficial fibula. So I mean, you have different parts of that innervates, and you can look if you want to look at what they innervate and all the different skin, etc. And there's the summary for that, all of that, and all of these things: herniated disc, obturator nerve, sciatica, all sorts of different problems are associated with it. Foot drop, again, something that can be by putting pressure on those nerves, particularly when a cast is not applied. The nerve winds around the neck of the fibula here. So we would put a cast on, we call it a short leg cast. You palpate the head, the neck of the fibula, the head of the fibula. Take 2 finger breaths, and the cast would go to the below those 2 fingers. So there's all of these anatomical landmarks. Everybody have a wonderful weekend. Have fun storming the castle. I see.